Okay, we're ready. Hi everyone, I'm Lori Hoffman. I'm a partner at Ovation Lab, and I'm really delighted to welcome you all today to another episode of Innovations in Clinical Implementation. We're translating leading-edge tools into strategies that practitioners can use and apply directly with patient care and in your practices right away. We're here live at Longevity Fest 2025, surrounded by thousands of clinicians, 8,000 as a matter of fact, advancing metabolic health, GLP-1 based care models, and weight optimization. So today we're joined by Dr. Myles Spar and Dr. Ed Walker to explore how Calocurb's triple satiety hormone activation can support weight health, improve metabolic outcomes, and strengthen continuity of care, including before, during, and after GLP-1 therapies. Dr. Myles Spar, MD, MPH, is a leading authority in personalized performance and integrative men's health. He is Executive Medical Director at Wonder Health and Senior Medical Advisor for And Health, and a double board-certified physician in both internal medicine and integrative medicine. Dr. Ed Walker, PhD, is the lead scientist behind Amarasate, the New Zealand hops extract at the core of Calocurb's natural appetite control formula, a researcher at New Zealand's Plant and Food Research and Bioeconomy Science Institute, and guest lecturer at the University of Auckland. His work for the past 13 plus years is focused on plant-based appetite regulation, GLP-1 and satiety hormones, and clinically validating nutraceuticals for weight management. Welcome, Dr. Spar and Dr. Walker and Dr. Lexi Gonzalez, who you've all seen in some of the podcast episodes to date. But Lexi is a senior clinical implementation specialist with Ovation Lab, and we're just really delighted to have all of you here today.
Great, good to be here.
Yeah. So I'm going to kick it off actually with you, Lexi, and just ask you to talk a little bit about GLP-1s generally speaking, and then some of what we've both been learning and some of the work that we've been doing with Calocurb on some of these protocols, and in particular the de-escalation or also Amarasate or Calocurb as an alternative to GLP-1s.
Yeah, that is a loaded question. So I'll start off with, there's been a huge resurgence of individuals and patients and practitioners who have started to implement GLP-1 injectables into their clinical practice. And one of the benefits of working together is we've been able to create this functional medicine framework to really support the community at large for how we can really best guide patients through this process. And through that, involvement in this collaboration, we've created protocols and educational webinars to really support practitioners and patients with a whole person care protocol that integrates diet, lifestyle, ingredients like Amarasate from Calocurb, and how they can safely, use the lowest effective dosing strategies and safely come off of it and maintain those results. And so clinically, what we're seeing is two major concerns. How do patients preserve muscle while they're on the injectable? And then how do they actually maintain the weight loss that they've been able to achieve with GLP-1s? So I'm curious, Dr. Spar, do you feel like this is something that patients should actually be concerned about? And do you see this in your practice?
Right. Thank you. Good to talk to you all about this very important topic. Because yes, a lot of patients are on GLP-1s or are asking about GLP-1s. It's hugely important. The muscle mass question is hugely important. We had heard about it as a theoretical concern maybe a year ago. Now we're really seeing it. I've had patients come off of it. And in my practice, we are very serious about doing functional assessments of all aspects of longevity, one of which is looking at muscle mass, either from a DEXA scan to actually look at muscle mass, or functional testing like grip strength. And we've seen that go down in patients on GLP-1s, even at lowish doses.
Wow.
And then when we look and we can see from the DEXA scan that, yes, they're losing weight, but they're losing as much lean muscle mass as fat mass. What's interesting in longevity, I did a deep dive into the research into this, and actually, lean muscle mass is more predictive of longevity than fat mass is. It's that important. And we know that. We've all heard grip strength correlates. We were talking about this earlier, that thigh muscle diameter is actually directly correlated with longevity. So we cannot be losing muscle mass even if we're trying to lose weight. That is going to defeat all the purposes. I've had patients come off of it for that very reason. Because we're checking these DEXA scans, we see the numbers come down, going in the wrong direction. Plus, what you didn't mention are side effects. I mean, we see a lot of side effects, even at lowish doses. Certainly, some of them get better as you decrease the dose, but some of them don't. A lot of digestive issues, not only lower in terms of constipation, but a lot of upper digestive issues. I have had patients that no matter what we try with our functional therapies, they're still getting a lot of kind of GERD symptoms, upper digestive symptoms, burping. So for several reasons, I think it's important. And then the weight gain, if we do try and de-escalate or even maintain at a lower dose, we do see some of that weight coming back on for several people.
And I think something that's really important about what you said is the functional assessment that you're doing, which makes me think that there needs to be some sort of reframing around how we're actually talking about weight versus being more specific about body composition.
Exactly.
So I'm curious, what exactly is part of that functional assessment that you do? You mentioned DEXA scan.
DEXA scan ideally, if you can, right? That's the gold standard. But at least if you're not doing that, at least checking, even just measuring, a tape measure you can do, right? So, and using waist circumference as a measure of fat loss, if you're not able to check body fat percentage, and then measuring the muscles that are most significant. So I mentioned thigh, so thigh diameter, making a little mark somewhere where you know where along the thigh to do it, biceps and chest, pec. Just those 3 areas are probably sufficient, and really making sure, because you will notice a difference, unfortunately, especially at the higher doses of GLP-1s in just a few months, and those shouldn't go down at all.
Right. And where do you feel like clinicians get the most stuck in trying to maintain weight loss or maintain this lean muscle mass that we're trying to preserve?
I want to say pressure from patients, and that sounds horrible, but this whole field is being driven by patients, which is great. So I hate to make anything negative sounding around pressure from patients, because by and large, the pressure from patients is what's driven us forward. And thank goodness for the patients driving it, because we as clinicians really haven't been ahead of the curve. The patients have, but sometimes we do get intimidated by our patients who say they're ordering it online, or they're just going to find someone else and they're going to do it. So then we kind of say, well, you're going to do it anyway, but we're not having that conversation with them about using a whole protocol. Fine, I'll give you this GLP-1, but let's look at your nutrition, your protein intake. Let's look at other supplements that can help, HMB or other things, or alternatives like we'll start talking about, like Calocurb, which actually is working with the body as opposed to just exogenously putting things on the body, with amazing success, with less side effects, and actually potentially even the opposite of muscle loss, not causing the muscle loss, maybe even helping muscle gain, which we can talk about. So I think in answer to your question, it's the patients really pushing, and doctors, not any fault of their own, they just don't have the time, like, all right, I'll just write the prescription and not discuss the nutritional support and the supplement support that could be done either in addition or instead.
Right. And I think that's also driven just by the transparency that patients have among each other with their results and posting on social media. And they feel very motivated by the quick results that they're seeing among their peers.
Exactly.
So I'm curious, how are you weaving in Calocurb into your protocols when you're putting someone on a GLP-1 or taking them off?
Yeah. I get really excited about it because I think I was one of the first people to start using it.
I would second that.
I've seen that it really works. It really works. So honestly, that's the first thing I say. I say, okay, great, I get it. Well, did you know there are ways to actually stimulate your own production? And maybe we will go to the pharmacologic approach, but why don't we try first? Let's look at your diet, your sleep. Let's look at the majoring in the majors. And if we do feel we need to help with GLP-1, let's look at some natural ways to do that. Everything from time-restricted eating to Calocurb. So it's not just Calocurb, but that's part of a whole lifestyle approach that's a little more gentle and working with the body. And they all know that's my style anyway, and I'm not anti-pharmaceutical, but when that's appropriate, great. So usually I start right away saying, let's just try this. Let's give it 3 months, see how you do, see how your weight does, and do the DEXA scan before and after.
And dosing-wise, how do you weave in dosing for Calocurb with a GLP-1?
Yeah. Well, first I tried without the GLP-1, and I use, I go up to it's 250 milligrams twice a day, starting at half that for a little while, and there's a very clear cadence recommended by Calocurb, and so I'll go up to the 250 twice a day. And then typically, if they're not achieving by 3 months the results that they want, that's when I'll add in the GLP-1, but I'll maintain that same dosing of the Calocurb in order to use as little GLP-1 as possible. And we start out with a very clear goal. Like, we're not just going to start GLP-1 and see how low can you go. I mean, we're like, okay, what's healthy? What are we trying to achieve in terms of body fat, in terms of blood sugar, in terms of waist circumference, whatever the measure that matters to that patient. And then, so that way they can't keep moving the needle or the goalpost on me.
Right. And I think that's a really important part, is this, not only the behavior shift that's associated with the GLP-1 injectable, but with something like time-restricted eating and the Calocurb dosing. And so I'm hoping that, Calocurb just launched a new practitioner-only product. Calocurb Clinical. So I'm curious, Dr. Ed Walker, if you could dive into what is the differentiating pieces to Calocurb Clinical from the standard formula?
Right. So at a fundamental level, it's the dosage. So the Calocurb Clinical comes in a 250 milligram dose, and the standard Calocurb's in a 150 milligram dose.
Okay.
Now, 125. Now, you'd normally think that, you can just take 2 capsules and then it'll be the same. But because of how Calocurb works, it's a little bit different. So because when you take a Calocurb capsule, we're trying to stimulate your body to produce its endogenous GLP-1 and release that. And so we have to target the surface of the small intestine. So we need to get the pill from the stomach into the small intestine release, and then we're focusing on getting a high concentration around the surface of the intestine. Now, if you take 2 125 milligram capsules, you get 2 small concentrations moving down the gut, which can stimulate the hormones a little bit. If you get 1 250 milligram capsule, you get a large concentration present in the gut. And as that large concentration moves down the gut, it's more able to stimulate the release of those peptide hormones. So your natural GLP-1 as well as CCK and some PYY.
Gotcha. And just out of my own curiosity, what was the motivation for creating a higher dose in a single capsule?
Yeah, so I think that when the product first came out, it was very much consumer focused. And there's different requirements when you have something that's going to be sold directly to consumers. They're much less likely to follow instructions. They're not going to tolerate any side effects, whether they're minor or not. And so we really went, well, what's a dose we think we can give which is going to be effective but also be really well tolerated, even if you possibly don't follow the instructions very well. And so we went with the 125, but as Calocurb has matured as a company and got really more doctors using it, there was really a requirement for something that was maybe able to bridge the gap a little bit more between normal Calocurb and a GLP-1 type injectable. And so that was where the shift to the Calocurb Clinical came. And it was really saying, okay, if we can manage it through a doctor, then higher doses are safe. So we may as well see if we can get more GLP-1 stimulated. May require a little bit more management in case people are a bit more sensitive and get some gastrointestinal side effects, but that's okay through a clinician.
And have you been able to measure or see an increase in GLP-1 activation with the 250 versus 125s?
So what we're able to see is when we do our cell-based experiments, if we deliver two smaller concentrations to the cell, they're much less responsive than giving one larger concentration to the cell.
So interesting.
Yeah.
I mean, finally, we're hearing this. I mean, not finally, but I've been eager to hear the answer. We've been asking about it and wondering ourselves, right? But you heard all of us as you spoke. We're like, okay, now we get it.
Because I think it's quite counterintuitive, because normally drugs are targeted towards the blood, and so 125 being absorbed into the blood is exactly the same as 250 being absorbed into the blood. But it's just different because of the way we're targeting that gut surface.
And I would say one thing from a clinician perspective, I love that y'all thought of this, because most people don't, is they package it with some of the 125s in there in the package. So because typically you do start at the 125 dose once a day and then twice a day, and you kind of ramp up to make sure there aren't side effects, make sure a patient tolerates. And I appreciate that, because a lot of supplement companies would say, well, let's make them buy a whole bunch of 125s and a bunch of 250s in order to follow that on-ramp. So it's nice that it's all and it's very clear.
And it's also super smart. I think because for patients that might have started with a 250 and maybe they had a little bit of discomfort and now they're abandoning it rather than being able to do this, ramping up.
Exactly.
Right.
Yeah.
Yeah, and I also think that it's I was listening to Myles actually, and I think his approach is really excellent. That starting on the Calocurb and then putting the semaglutide on top of it, because one of the things that I've always been a little bit concerned about with semaglutide use is that knocking down of your endogenous GLP-1. So we've seen the study with liraglutide where they give liraglutide to people 14 weeks later, their endogenous GLP-1 is really low. So then if you're going to remove the liraglutide, then you'll have a problem with sudden hunger coming back. Whereas if you're easing on to the semaglutide or the trizepatide treatment using Calocurb first, you can use the littlest amount possible
Yeah.
to get an effect, and that way you're preserving some of your endogenous hormones. You're less likely to knock them down.
I love
Interesting.
that.
I
Yeah.
love that. That is good. See,
Yeah.
I never do it for a reason.
I mean, in
Yeah.
the context of health span, sorry
Right.
to interrupt, Miles, I think that's super important, right? Is to
Yeah.
provide a solution that can last with you throughout all the phases of your life versus being the same thing that you take
Right.
consistently.
And not shutting down something in your body,
Yes.
right? I mean,
Exactly.
that's what I really got, is that while you're providing that, support of the semaglutide, the Amarasate or Calocurb is helping us to maintain our own GLP activation.
Right.
You've got something. You've got a
Yeah.
compound there telling your body to produce GLP-1.
Yes.
Whereas when you inject the GLP-1, you've got a compound telling your body it doesn't need to produce
Right.
GLP-1
Yeah.
anymore. So at least you've got that counteracting force.
What are you noticing with any side effects with the 250 versus the 125? Anything?
Yeah, I mean,
Or symptoms?
what we find is really that there are some people who won't tolerate the 250. Right? So they get on the 125 and it's all right, and when they jump up to the 250, it's just a little bit strong for them. And by a little bit strong, I mean some gastrointestinal side effects. Right? They can most of the time, if they want to go through a process of taking it for a week or two, those side effects will go away. But not everyone wants to do that, and they might drop down again. There is the odd person who is a little bit more sensitive and just won't tolerate it. That is a little bit of the downside of having the gut target, because the gut is much more variable between people than, say, if you're concentrating into a fixed volume of blood. But the gut target also gives us quite a good safety profile, because we're not requiring it to be absorbed into the blood. We're not requiring it to go through the liver and have to do metabolism. And so it's quite a safe place to target.
Yeah.
And I'm curious, Dr. Spar, then having now two options, both Calocurb and Calocurb Clinical, how might you weave this into your current protocols and differentiate when you might use one product versus the other? Kind of touched on it.
Yeah, I'm excited about the clinical. I have pretty much everybody on the 250, honestly, just because I haven't found that bad of side effects. I do ramp them up starting at 125, number one. Number two, most of them have a lot less side effects from it than they would from the GLP-1s. And like you said, I just tell them, just stick with it. It usually goes away really quickly. So I don't really have anyone on just 125 for the most part. So it's typically 250 twice a day. I have some people that take a little more. I don't know if that's allowed or not. Okay, especially some bigger guys.
Clinical Pearl.
Yeah, but a lot of times, and those are typically the people that are night eaters, and we're trying to do time restricted eating. So for that second dose, they'll take like 3 of the 125s because the 250, again, it's only for a subpopulation. They were still finding they would start to get some late night
Grabbing the pistachios.
Yeah, exactly. But that's
Yeah.
probably shouldn't be included in this whole podcast. Probably not on label or anything.
There's fundamentally no safety issues I can see from that. The product is pretty safe, and we get very limited absorption into the blood. So we did that bioavailability work with less than 0.1% of the oral dose going through phase 1 or 2 metabolism from the liver. So it's a pretty safe product.
Oh,
So I wouldn't worry about it.
Right.
Heard it here first.
Yeah,
there you
Dose a
go.
little
There
higher.
Also, I'm not a medical doctor.
Exactly.
We have all the proper
We'll flash all the
disclaimers.
disclaimers.
Yes.
I know we have to wrap up, but thank all 3 of you for this episode.
Calocurb, proven in clinical studies to reduce hunger by 30%, food cravings by 40%, and caloric intake by 18%. Calocurb helps you feel full for up to 6 hours after taking 1 hour before a meal. The active ingredient in Calocurb, Amarasate, is a bitter hops plant extract developed with $30 million in funding and 14 years of research. Calocurb is here to help reduce your hunger and cravings and provide that feeling of fullness to comfortably curb calories.